Hi, everybody, and welcome to this session. I'm George Valiotis. I'm the Executive Director of the European Health Management Association, and I'll be moderating today's session. This session is titled Winter is Coming, the Burden of Respiratory Syncytial Virus, or RSV, on Health Systems in Europe. EHMA has a long interest in health system disruption and RSV, and this is our second year with a dedicated RSV session. So RSV is a leading cause of respiratory illness in children and a major contributor of the winter pressures that burden healthcare organisations in Europe. Towards this, we are interested to know what RSV does to the healthcare system and measure it through disruption. This session will begin with EHMA's ongoing survey on the burden of RSV on health systems in Europe. And then in the discussion to follow, we will explore the system-wide pressures that affect health system performance in the peak RSV season, current practices for the treatment and management of RSV in the community and hospital care, and the optimal approaches and strategies required to manage RSV infection in the community. This session will last for 75 minutes, and today we have an impressive panel of experts for an interactive discussion. You can see them all on the screen right now, and I'll introduce them one by one in a moment, and then we'll get started. So let me start with the introductions of who will be joining us today. We've got Dr. Christian Felter. He's the global medical expert for nosocomial vaccines at Sanofi Pasteur. Hi, Christian.
Good afternoon, George.
Thanks for joining us. We also have Professor Javier Diaz-Domingo, medical doctor. He's the head of vaccine research at the Department Center of Public Health Research of Valencia, otherwise known as FISABIO in Spain. Hola, Javier. Thanks for joining us. Great to have you here. Next, we have Dr. Callum Bumblut. He's the president of the European of General Practitioners. He's a family physician at WEMO and a senior family physician as well at the Satu Mare Family Physicians Association of Romania. Hi, Callum.
Hello, George.
Thanks for being here. And now Professor Susana Esposito. She's the director of the Pediatric Clinic, the Department of Surgical and Biomedical Sciences at the Università degli Studi di Perugia in Italy.
Hello to everybody. Now I am in Parma, not in Perugia. I am more in Perugia.
My mistake. Thanks for letting us know. And we have Dr. Simon Nadell. He's a consultant in pediatric intensive care at St. Mary's Hospital and Imperial College of London. Hello, Simon.
Hi, George. Thanks for inviting me. Great
to have you here again this year. And finally, we have Dr. Francisco Ribeiro Murao. He's at the Department of Pediatrics, Centro Materno Infantil de Norte in Porto Centre and the University Hospital of Portugal. And he's also the treasurer of the European Junior Doctors. Hello.
Hello, George. Hello, everyone. And once again, thank you for inviting us to join you today.
So it's an amazing panel. You're going to hear from the panel in a moment. But to get us started, I'm going to go to our first speaker. But before we do that, I do just want to say to you that you're welcome to put forward your questions at any time during the presentation. Feel free to use the comment section on the right side of your screen for any questions you might have, and we'll address them with the speakers at the panel sort of after the main presentations. So let's get started now, and we're going to have Dr. Felter do the first presentation. He's going to kick off the discussion with a short presentation on the health burden of pediatric RSV and the associated disruption to health system performance. Over to you, Christian.
Thank you very much, George. I'll be bringing up the presentation right as we speak. All right, hopefully you all can see this. So good afternoon, everyone. I'm here just to give a quick overview of RSV, Respiratory Syncytial Virus, which is definitely an urgent and immediate threat to all infants, to just baseline what we're talking about when we talk about disruption to the healthcare system caused by RSV. So RSV causes disease across everyone's lifespan. It causes lower respiratory tract infections in the young, so newborns and infants, all the way up to respiratory illnesses and exacerbation of asthma, COPD in the elderly. So it's something that is definitely along with us for our entire life journey. To focus in on one of the things that is of key importance is really the impact of RSV on infants. You can see there are over 33 million episodes of RSV, lower respiratory tract infection globally in this population alone, leading to millions of hospitalizations, emergency department visits, and outpatient pediatric visits. And I'll go more into that as we go through this presentation. When we look at where RSV sits with regard to acute respiratory tract infections worldwide, you can see here that almost 2/3 of the respiratory tract infections in this population in infants is caused by RSV. That's dwarfing what we see in some of the other more commonly discussed pathogens there. Not saying any of these pathogens aren't important, of course they are, but we're saying when we talk about a healthcare burden, we're looking at RSV as one of those that is definitely dominating when it comes to respiratory tract infections in that age group. The severity of RSV in infants is unpredictable, and you can't tell who's going to be having a severe case. It can go from mild flu-like symptoms, as they would call, all the way up to cyanosis, hypoxemia, and the like that requires mechanical ventilation in the intensive care unit. And so it is very important to understand that we cannot predict which infants will suffer mild symptoms or severe disease. And as we see there, it is definitely something that is a burden across the healthcare system. At present, only supportive care is available, which means that the healthcare systems are going to be taxed by having these patients in the hospitals, because once they're hospitalized, they're going to need oxygen, suctioning, IV fluids, and at times mechanical ventilation, because that's the only thing we can do until the infant is able to clear the infection on their own. If you take a look at some data coming out of the United States and emerging data out of Europe shows similar sorts of things, that we know that the RSV is the leading cause of hospitalization amongst infants. And actually, if you take a look at some of the other leading causes, you can definitely see that there are other ones which are associated with RSV, but may not necessarily be diagnosed as such if it's not tested for. Definitely a burden on the healthcare system. And actually, when we take a look at it, the burden of RSV on the healthcare system and the patients extends far beyond the hospital. In the short term, even after discharge from hospital, there's an increased incidence of otitis media, pneumonia, and excessive antibiotic use. And in the long term, recurrent wheezing, decreased pulmonary function, and overall increased healthcare utilization, which means that even once they are treated successfully, we're going to be seeing ongoing use of the healthcare system. What I showed you there previously is one of the things that is often focused on, which is the burden of RSV when we talk about hospitalization. This is data, again, from a recent study that was published out of the United States, showing that hospitalization, while extraordinarily important, is really just the tip of the iceberg. When we take a look at the overall burden on the healthcare system, hospitalizations, while very important, are just a small fraction of the overall medically attended lower respiratory tract infections that end up in the hospital system, as you can see here, between emergency visits and pediatric practice visits. And with that, I hope that we've had a chance to sort of baseline where we're start talking about, and I look forward to hearing the rest of the experts speak. Thank you very much for your time.
Thank you so much, Christian. Thank you so much for giving us that introduction and helping us really understand what is RSV and why is it important and why now. So thanks for doing that. So next, what we want to do is hear from Professor Diaz-Domingo. So he's a co-investigator on the research survey that Emma is running, and he's going to present the survey methodology and our preliminary results, remembering that the survey is still running. So if you're interested and are working in RSV or respiratory illnesses, do look out for it. But to hear more, I'm going to hand you over to Javier. Javier, thank you so much for presenting the preliminary results.
Okay, thank you, George, for the opportunity to present these very interesting results. Next one. First of all, my disclosures. After more than 25 years doing research, I have been collaborating with most of the companies. Next one. Yes, thinking about RSV, and thank you, Christian, for the introduction. What we know is that RSV affects over 95 or infects over 95% of the children at the age of 5 years, and up to 4% of those children are hospitalized. And the hospitalizations occur with a seasonality which lasts about 2 to 3 months, extending in Europe from November to January. So there's a huge number of hospitalizations in a very short period of time. And that clearly may overwhelm all the health system resources. That is why it is important, next one, to assess the perception of the healthcare providers about the RSV burden and also about the disruption that the annual epidemics causes on the health system. When we refer to the health system disruption, we are it will be a whole concept that will include the increased demand for care. Very important are the nosocomial infections, children that are admitted by one disease and they are infected by RSV during hospitalization. And also very important is how this overwhelm in the health system may affect the staff performance. The study or the survey that we are already conducting has directed to all healthcare. So for primary care, hospitalizations, primary pediatric intensive care, and emergency medicine. And we requested their impact during the last 3 RSV seasons. But take into account that the last one, 2021, there was hardly any RSV because we were all with the pandemic of COVID. So some of these results will be decreased or will not show the overall impact of RSV. So far, when we did the cut of the survey, we had nearly 100 responders, and of those 100 responses were scattered through Europe, as you see in the image, with more respondents from the UK, from Finland, and from Croatia. And we had representatives from both primary care and hospital, with a wide variety of professionals answering the questionnaire. Next one. So, just summarizing the results, and I keep on saying that this is an ongoing research. 95% of the responders of the questionnaire think that the healthcare system is under pressure during the RSV, and that means that there's a disruption, which is from moderate to extreme. Very few of the healthcare providers that have responded think that the disruption to the health system is minimal or low. Next one. And as I mentioned, we did the survey in different areas, and we requested why they felt that there was that disruption. And the responses were similar, but with some differences between primary care, hospital, and pediatric intensive care. So for primary care, it was important that they, in the RSV season, the healthcare providers had to work more hours than due, because they have to attend a huge number of children each day. And also they found difficulties in attending other pathologies or referring sick children to the specialist. So it is very related to the primary care. For the general wards, pediatric general wards, it was important that the RSV season increases the number of hospitalizations and therefore decreases the capacity of the ward or the hospital to admit all the pathologies, and then therefore there's a delay in some other treatments that strengthens the system. For the pediatric intensive care, the delay in treating other diseases is important, and also it is important that it breaks this overwhelming season, breaks all the routines of the intensive care. Routines in intensive care are very important to have a better outcomes. Next one. So when we ask the most important how it affects the outbreaks affects the staff. Differences are also important among settings. For instance, for primary care, the staff turnover, it is important and it's very distressful. Burnouts, I think most of European health systems are at a high level working, and therefore any season burns out the healthcare providers. There's also an increased workload, which is the reason of this burnout, and that brings a high number of of sick leaves among the healthcare providers because of the burnout or the excess of work, and that brings the high staff turnover, and at the end, that means that is a disruptive healthcare system. Next one. If we go to the bed occupancies in general wards or also in intensive care, we see how respiratory infections during the RSV season are overwhelming other causes of hospitalization. You see in summer about 15% of the hospitalizations are due to respiratory pathologies. However, during the winter season, and especially during the RSV, is always over 50%, both in pediatric intensive care and in the wards. Take into account the complete different situation in the last season where we had the COVID circulating, and there was very small number of RSV cases. Next one. And also very important, the treatment of RSV severe diseases is not etiological, it's just supportive treatment. And that means that there are many different treatments, but none of those, or very few of those, have shown that are evidence-based and are effective. And therefore, the guidelines are unclear, and as a healthcare providers, we tend to be very active in the treatment of subjects. And when we see how cases of RSV are treated, we see that a lot of interventions which are not evidence-based are performed, like for instance, the very large use of antibiotics. About 30% of children attended with RSV in primary care are given antibiotics when this is a viral disease, but just in case. Also in the pediatric intensive care, anticholinergic, inhaled anticholinergic with bronchodilators are very widely used in primary care, nearly 50%, as these are the inhaled or oral corticosteroids. Leukotriene, nebulized adrenaline that has shown that has no effect on bronchiolitis, nebulized bronchodilators are very widely used with no clear effect. So what we see is that there is a huge heterogeneity in the treatment or in the management of these children, and most of these interventions are not efficacious and therefore shouldn't be used. Next one. And when asking the healthcare providers, what should we do to improve or to decrease this disruption? So most of the healthcare providers said that the healthcare system need a reorganization to decrease the impact and to decrease the nosocomial infection. The most important factor that bring out the healthcare providers is that hospitals and also primary care needed very important infection prevention measures to minimize this transmission of the virus in hospital or in primary care. Also, very important training on the personal protective equipment, which is very scant apart from the COVID situation or the COVID pandemic. It's also very interesting that the healthcare providers think that the early diagnosis of RSV may decrease the impact, and therefore they request for a point of care testing, especially in primary care, so that they will be able to isolate and decrease the contact of these babies with others in the waiting room. And also it is very important for most of them is how to do not block the health system and prioritize not by the waiting list, but of the severity of the disease. So it also needs an important change in mentality. So there were other less voted areas of interest. Digital technology, as they think, and we may have learned that with the COVID, that virtual visits or using digital technologies for visiting may also improve the health system. So there's a good number of possibilities to improve or reorganize the healthcare system. Next one. And over 80% of the healthcare providers think this is a very common, potentially severe disease with no treatment, and prevention should be the hallmark. For 1 out of 3, it is the most important, a very important situation, and for 50% it is important. So I think that once we have a potential preventive preventive medicine or vaccine, we should use that, because the RSV is overwhelming and disrupting the health system. Next one. So as a summary of what we've been said, is that RSV is a significant suppose a significant pressure over the health system, especially during the peak. The reorganization of the health system to minimize nosocomial and better care of children is a top priority for healthcare providers. That there's a huge heterogeneity in RSV management, and therefore that means an extra cost and more visits. And just to finish, that this survey is still running, and we expect to have all the answers that we requested by mid-October. Maybe next time I will show the whole results. Thank you very much.
Thanks, Javier. That was beautifully presented, and really interesting to see where that data's up to. And I hope you do come back to present the final findings once we have them, as you mentioned, in mid-October. What I'll say to the audience just now is, I can see one question's come in already, and I'd encourage you, if you do have any questions, please do add them to the comment, because we will be coming to them. I'd like to now invite the panel to join us, and we're right on time, in fact a wee bit early, to now come to the panel discussion. So everybody that I introduced earlier is just returning. Thanks again for being here. To start us off, Javier, I want to come back to you, because you presented the data as we've collected it and presented it. But for you now as a professional, like, what is your first take on the data? Can I get your initial response as a professional to what you're seeing in that data?
Yes, I didn't answer this question, but about 25 years ago, I wrote a paper which meant the title was RSV, the pediatrician headache, the annual headache, because it is overwhelming. I used to work, I have worked both in hospital and also in primary care, and all the clinics are overwhelmed by children with respiratory diseases, and most, I feel that the answers that I've been presenting to the questionnaire, I would sign them, all of them. So from the personal point of view, I think that having a preventive medicine or preventive vaccine for RSV is a key in the pediatric world.
Okay, so does anybody else want to share some initial findings to the survey? I'll come to you with individual questions, but just now that you've seen the initial survey, are there any other comments? Otherwise, I'll move on to some other prepared questions I have.
Yeah, if I could just say, I'm coming from an intensive care background. I was interested to see that much as I know that RSV has a major impact on intensive care units every year in the winter months, I was interested to see it has just as much impact on primary care.
Yeah.
And although I was aware that many respiratory infections are attended by primary care, it's interesting to see that the effects on the staff in primary care are just the same as they are in hospital. So that to me was kind of an interesting finding.
Yeah, Javier.
Yeah, taking into account that most of the guidelines say that with oxygen saturations over 92, they shouldn't be admitted, especially in this peak season. That means that we can have babies 2-3 months of age with 93-94% oxygen saturation in primary care, being attended in primary care, that they are tachypneic, they are difficult to feed, and that's a headache for the family and for the GP or primary care pediatrician. So from hospitals you see the most severe cases, but in primary care the burden is amazing, and it is sometimes very worrying when babies are not admitted and you do not trust the family. Many nights I have had problems in sleeping during the RSV.
Yeah. So Susanna, you had some comments as well?
Yes, my comment is related to the impact of COVID-19 on RSV burden. So I think that it will be interesting to understand what will happen in this season. I was really impressed last year for the reduction in the burden due to the mask, due to school closure, due to several different change in the life of everybody. But I think that this year we need to be very careful with topics like RSV and also flu and the concomitant circulation of the different viruses. Also understanding the possible co-infections between 1, 2, or even 3 viruses.
That's a good point. I'm going to come back to you actually with some questions about COVID and post-COVID. So let me actually come back to another question now, because the title today is Winter is Coming, and I'm here in Lisbon now, and it is pouring with rain. And Francisco, I know that you're in Porto. I don't know if you've got the same weather, but I'm wondering, like from your experience in Portugal, how have the findings resonated with you?
So, yep, not raining in Porto today, but yeah, we had heavy rain the last days. This year, at least here in Portugal, and I guess in majority of the European countries, we are seeing a shift from the usual burden of RSV, and it prolonged a bit to the summer season. And this overly meant an overcharge for the systems, especially in terms of hospitalizations. So the usual things that we were used to see in the summer in hospital was not what we used to see, and that probably has been a result of the wide use of masks, as well as wide use of hand hygiene measures and schools closure. And let me just add one thing from what was previously discussed, and one interesting finding here as well, that I think that needs to be worked on. We are talking about the burden of RSV, which is patient and family education. And we have seen that hospitalization is just the tip of the iceberg, and we have much more. And what happens with RSV patients due to the natural course of the disease is that these patients go multiple times to multiple settings. So they start with 1 or 2 visits in primary care. Then on the 4th or 5th day, they go to the hospital. They come back again to the hospital, and in the end, they end hospitalized. And I think one of our top priorities should be also a bit in terms of prevention, let's say, in terms of patient education, because these patients do go to different settings in the same episode lots of times. And this is also something we should focus a little bit. And I also wanted to add that from what Javier presented. We also need to be aware of this. These patients go multiple times to different settings on the same episode.
Thanks, Francisco. I see there's a question from the audience from Tina Hadjis. So if that could come up on the screen, please. And what I'd like to do is come now to you, Callum. So as a senior family physician, you're working in the primary care setting. We've heard about the surprise that the primary care setting has been equally impacted as the nosocomial setting. And certainly that's why EHMA have been interested in RSV, because it's something that affects the whole health ecosystem. It's not just stuck in hospitals. And that's why we think as a disruption, it's quite interesting to address. So Callum, what I want to ask you is, how well of RSV infections are primary healthcare professionals in Romania? Do you think it's well understood? And we have you on mute, so you might want to just undo your mute button.
Sorry. Before giving the direct answer, I want to comment a little bit about the study, and thank you very much to Javier for this. As being only preliminary data and is linked with the answer that will follow. I would like to refrain from commenting much about the study, but this data must be consolidated and validated on a larger group of respondents from several European countries. It's obvious. This could be one of the reasons why preliminary responses point to considerable heterogeneity in practices for RSV management between primary care and hospitals. But I would like to, I would still notice the similarity in disruptions of work of the primary care with pediatric intensive care units. This is very, very interesting similarity. And comments about the use of antibiotics in primary care. We use quite a lot of this in primary care because we are in the front line. Often virus disease is complicated by bacterial superinfection. We are responsible for preventing any possible complication with bacterial infections. There is also pressure in terms of legal responsibility in case of complication of the evolution of the disease. And of course, there are demands of liability of GPs regarding this complication from the society. And to give a response, in Romania, we are witnessing a lot of diseases during the winter time, but not only in this period. We notice some cases as well in spring and in late fall, and not in the summer are not the happy days as well as we are thinking. In primary care, of course, depending on the countries, the way of organizing the primary healthcare in different countries. But in my country, for example, we are in charge with the diseases from the cradle to the grave, as are saying about this. In other countries, the primary care is involved in diseases from, I don't know, from 14 years or 16 years and go ahead. The differences are not so bigger between the countries, but of course, regarding the question about the health literacy among population, the primary care is in the front line as well in education of population, and not only in this, but in primary prophylaxis, because the knowledge and observance of general measures of prophylaxis and control of infection is the most important method of prevention, not only for the RSV infection, but generally speaking for all diseases, and in this time of COVID pandemic is the utmost importance, the general measures of prophylaxis. And of course, informing and education parents on the means of preventing infections in infants and young children. It's a very important standard for the prevention of RSV infections. I don't know if I answer enough for this question, but Romania is not different from other countries. And as you presented me, I'm the president of UMO, the European Union of General Practitioners, Family Physicians. And in my quality of president, I represent here over 400,000 general physicians, general practitioners across Europe. And we notice that we are not very different one of each other in this work, in this struggle against pandemic and against infectious disease, and of course the RSV infections are included as well in this.
That's really interesting. Thanks, Callum. And interesting to hear your comparison of Romania. And it's true what you say, that getting a bit more data help us validate a really amount of information to better understand how does this move all across Europe. So just to dive in a little bit deeper, still with you, Callum, on how do you believe that RSV bronchiolitis can be managed within the community? Like, you've made some comments about that.
Please repeat. I didn't hear about bronchiolitis.
Yeah, what we've been learning about RSV is that in primary care, it's mostly bronchiolitis that we talk about because it's not being tested and diagnosed. So what do you think are the ways that it can be better treated within the community? People have talked about.
Okay, thank you for this question. It's not about only bronchiolitis. RSV is the leading airway pathogen in infants and is a major cause of lower respiratory tract disease in young children. Of course, we are aware that the highest rate of illness in is recorded in children age 1 to 6 months, especially in those age to 2 and 3 months, and the number of diseases during epidemics is extremely high. As far as I know, it's reaching up to 100% in nurseries, where many children are prone due to age. How to reduce the number of this is the key point, I think, in all discussion. As I already mentioned, the primary gesture in this is to observance and to knowledge the general measures of prophylaxis and control of infection. And already I mentioned about the informing educating parents in regarding the means of preventing infections, not only in infants and young, but generally speaking in all population. Another step is to correct identification of groups of children at high risk for RSV infection, to search which candidates are prone to monoclonal antibody prophylaxis, for example, and to choose this prophylaxis. Another way is to correct identification of candidates for, as I said, monoclonal antibody prophylaxis, this being the main method of streamlining prophylaxis, both in terms of clinical consequences and in terms of cost benefits. And not in last but not least, follow-up of monitoring of patients immunized prophylactically with monoclonal antibody, which is mandatory for the evaluation of adverse reactions and clinical benefits. There are so many ways to follow up and to search the best way to manage the epidemic, the RSV epidemic. But primary care, it's a problem, let's say so, because, for example, the clinical guideline for the prevention of RSV infections are developed mostly nationally. For clinical protocols have a greater degree of flexibility adapted to the level of each health unit. But in primary care, as I said, apparently the freedom of individual practice gives even more flexibility. But if the clinical guideline is adopted at national level, obviously the degree of freedom is reduced. It's a little bit complicated to explain in detail for the general public, for example, how we are managing this, but I'm sure that my fellow colleagues are deeply understanding what I want to say.
Yeah, absolutely. They're really good comments, Callum. And in fact, I think as we keep getting survey results, all of these details that you're pointing to, we'll hope to better understand. And as we've shown the preliminary results today, but then we'll ultimately develop a white paper that not only will highlight the issues that everybody's pointing to, depending on what we get from the survey responses, but we're also asking people for best practices. So in the white paper that we'll publish soon, we'll be able to also highlight those. I'm going to turn now to the topic of COVID-19, and I'm going to go to Simon and then to Susanna with a question in a moment. What I'll say to the audience is I can see questions are coming through, and I haven't gotten to all of it yet, but I'm going to. They are certainly on my mind. So if you do have any questions in the audience, please feel free to ask them at any time. So thinking now of COVID-19, this current context that we're living in. So the survey investigates the impact of COVID-19 on RSV management. So Simon, what I want to ask you is, how has the recent experience of SARS-CoV-2 altered your view of RSV infection management?
Yeah, thank you for that question. Clearly, the impact of COVID has had a massive impact on the usual things that we see in children in the winter. So as I think Susanna said earlier, we saw hardly any RSV. In fact, no RSV patients were admitted to our intensive care unit last winter, whereas the winter before we were completely full of RSV. So we've had a very abnormal year, and the impact of that has been that currently we've now got three of our patients on the PICU here have got RSV. And this is completely unusual and atypical because we wouldn't normally see RSV till November or December, causing children to have respiratory failure needing intubation and ventilation. So the impact has been completely changing the epidemiology of RSV for the first thing. And we've been expecting a major surge in RSV infections, which hasn't actually transpired yet. But probably will come in the next few months. But also, I think the practice of infection control has completely changed the way we manage babies with respiratory infections. So now, whereas maybe our practice wasn't very good previously, but we didn't use FFP3 marks and proper personal protective equipment when managing the usual burden of respiratory infections every year. And that obviously had an impact on our staff because we had more staff sickness due to, and probably would have had more nosocomial infection. So now all of our aerosol generating procedures in babies or children who are ventilated on the PICU are being managed with full personal protective equipment, as they would for a SARS-CoV-2 positive patient. So we're using the same infection control practices that we're using for COVID. And that clearly will also have an impact on our capacity and our staffing ratios, because we're being encouraged to put children with respiratory infections into isolation cubicles. And obviously that's not possible, because it might have been possible with the few numbers of children with COVID, but we're going to see huge numbers of children with RSV and other respiratory infections. So COVID has had an impact on both the epidemiology of respiratory infection and the way that we're managing children with viral respiratory pathogens on the PICU.
Okay, interesting. Yeah, in fact, Francisco, I was going to come to you, so I can see you have thoughts.
No, just add something to what Simon said, and to the question that was on the screen by João Frutuoso. I'm not sure if the masks are going to change the burden, as it's a very special group, very, very young people. but I'm pretty sure that the practices within schools and kindergartens will definitely change this, and especially in what regards hand washing, not by the kids, but by the educators. So especially when these hospital staff and primary care staff are aware of the need for infection control measures, but now we have also schools paying some attention to this fact of infection control. And I think this could definitely change the burden of this virus. And it's probably an important lesson for the future. So I think more than mass, probably these infection control measures within the schools, which are also important, will definitely change the burden of RSV and other infections. And this is one of the big lessons of COVID, but I hope we don't forget them, because we forgot it from previous problems that we had, like influenza or other infections that we had previously.
Sure. I want to come to Susanna next, but I see, Javier, you have a comment that you want to add?
Yes, thank you. I completely agree that we have learned a lot of lessons from the COVID pandemic. But what I'm not completely sure is that all the impact that we've seen on influenza and on RSV is due to this physical distancing and washing hands and so on. So there might be some other explanations together with that. And my feeling is that the viral interference is very important. And I say that because we haven't seen influenza that last season. We didn't see RSV, but we did see rhinovirus and parainfluenza. So they were not affected at all by the pandemic. That means that infection control works, but needs something else. And in this case, my hypothesis, and this is what we are studying, is the viral interference. It's the only way that we can explain how the COVID vaccine has decreased the impact of some viruses and not others. And regarding the should healthcare system invest in education of the population, I think it is crucial. It is very important. And I think it is as important as vaccines, because otherwise we will always have lots of problems with the population. Thank you.
Right, interesting. Thanks, Javier. So, Susanna, I can imagine you've got a lot of thoughts based on what you've heard already, and I welcome for you to share any of your reflections. If you don't mind, I want to start by asking you a kind of a health management question. Given that last season's experience, do you see a risk of the burden of RSV as stretching beyond the winter season or displacing? Like, what do you think is going to happen?
You know, it is not very easy to, at the end, to predict what will happen. What I can say is that I agree with previous comments, especially for the awareness on the importance of prevention of pediatric infections in the first years of life. And this is good. I really hope that, for example, some more organized school programs can permit to really reduce the burden and increase awareness even among students. So starting from school-aged children, then considering those of the secondary school and also adolescents. Anyway, I'm also pretty sure that the teachers are now quite informed about the importance, for example, of hand washing, of prevention of respiratory secretions, and also the parents are informed that if, you know, this seems obvious, but this was what happened, that if you have the child that has fever or respiratory symptoms, the child cannot attend daycare. And so, again, this can impact on the circulation of the different viruses. What we observed also last year were some cases, not really outbreaks, but some cases of RSV absolutely beyond the season, the traditional season. So, for example, at the end of May or beginning of June, that usually is not a typical season for RSV in Italy. So this is something that could happen also this year. You know, probably now people are very tired of the closure, of the mask, of the hand hygiene, of everything. So it is true that probably the attention is a bit lower than that that people had last year. And for this reason, I think that we need to be careful with the circulation of the different pathogens this year. Really, at the end, in my opinion, the main period of circulation of RSV will remain the same, and so we should try to do our best to increase the vaccination against COVID-19, then also enlarging influenza vaccination, and then we should try to focus on an appropriate management of potential RSV cases, because now we will have, every time that a child has fever, the need to do the swab, and also the need to search not only SARS-CoV-2 but also RSV and flu. Then we probably could have some cases beyond the traditional period, but probably we will not have outbreaks beyond the traditional period.
Okay, that's interesting. We've still got 15 minutes of question time left. So just to let the speakers on the panel know, I've still got more questions for you, and the same for the audience. There's still a chance for you to ask questions. Simon, if I can come back to you, from what you've heard now from Susanna and from Francisco, does that also resonate with you? I know you touched on this before in your earlier comment, but could you say anything more about the timing of the RSV season this year, what you're seeing in the UK? Is it being displaced or shifted, or are we learning anything about predictability?
Well, I think the only thing that's predictable is that it's completely unpredictable.
Yeah.
So we were told, the modelers said that we would have a massive surge of RSV in July and August this year, which never happened. There were certainly many more cases than you would normally see in a normal summer in the UK. And I know that was mirrored in various parts of Europe and in the US and in Australia in their last summer. But I think what's happening now is that we're seeing this general increased burden of RSV, but not in a massive way that we would normally see in the winter. So I think no one really knows what's going to happen this winter. I mean, I think that's the worry, that we're prepared for a kind of coincidental surge of RSV, influenza, and COVID in the winter, which potentially could really, majorly disrupt healthcare systems, both primary care and in hospital and in intensive care. And already in the UK, we're seeing many more children with respiratory infections, not only RSV, but rhinovirus, as has been mentioned. We're seeing more adenovirus at the moment coming to intensive care, and we're much busier than we would normally be in a normal summer. And I know our general pediatric wards are full to overflowing, and we're not even near the winter yet. So I think there's a major concern that these three things will coincide and cause major disruption to the health service, which is already really running at full capacity. Yeah, and I guess we're hearing that consistently, and the data certainly is showing that, the slides that Javier showed earlier. So I think your point that the only thing that's predictable is that it's unpredictable. Right. And given that the theme of this year's health management conference is managing the present and shaping the future, Simon, would you have what would you say to health managers right now, as they stand here, as they're in the conference thinking, well, what do we do then in these situations? Is there any other reflection that you might have? Yeah, I think a big issue at the moment is staffing. Yeah. There are many staff that are kind of either burnt out because of COVID, or off sick because of isolation for COVID, or concerned about their children who have upper respiratory infections and having to stay off school, or being told to isolate. So I think care of the staff is primarily important. I think there's probably not been enough planning to increase in-hospital capacity despite COVID, because capacity is limited because of changing infection control practices, the need for more isolation, and therefore there's less capacity in the system. And those two things, both the staffing and lack of capacity, is causing a major impact. Now, as far as primary care is concerned, I'm not really involved in primary care. I'm not the best person, but I think from a hospital manager's point of view, it's increasing inpatient capacity, trying to improve flow of patients to get them in and out as quickly as possible, and look after the staff. Thanks, Simon. Callum,
we are interested in the comparisons, and you've already mentioned, Callum, the heterogeneity that we're seeing between primary care and in hospitals. Do you think that there is anything that we can do? Do you think that maybe the problem of RSV is underestimated in primary care compared to hospitals?
This is a difficult question. As I said, we are in the front line. It's difficult for us to estimate and to give figures about the incidence and morbidity and mortality and so on. Perhaps we know about RSV that is the cause of 20 to 25% of hospitalized cases of pneumonia in infants and young children, and as we speak about the bronchiolitis, the 70%, 75% of causes of cases of bronchiolitis is in these age groups is caused by RSV. We know that more than a half of infants at risk for the disease will become infected during an RSV epidemic. Those figures are perhaps frightening for the general population and are frightening for the physicians as well. And about the knowledge of mortality rate amplified by the spectrum of COVID-19, of course, it's aggravated by this. We know that mortality rate estimated with RSV infection relatively low, less than 1% in the absence of risk factors, but may increase to 10% in groups of children at risk. This is very difficult to manage from primary care point of view, of course, but together with our colleagues in the ambulatory system, in the hospital units, in intensive care units, and so on, we can manage as we already did it, of course. All of these are amplified, as I said, with the spectrum of COVID-19, and we are looking for everything now being as caused by SARS-CoV-2. Of course, this is not a real thing. We know and we notice that a lot of diseases are caused by other pathogens as well. But it's very difficult for us to convince a man that we must to follow up, to search, to investigate the cause of the disease, and there are many people reluctant to visit the primary care services because of the COVID-19. It's an intricate situation nowadays, and we already seen in the study that Javier presented us that in 2020 the number of the diseases are dropping down, but this is not a real thing. In reality, we know that a lot of patients are not seeing the primary care physician because of the diseases, because of the news from the TV and from mass media regarding the danger of going in community and visiting hospitals units and primary care units and so on. It's a difficult situation, but I'm convinced that we can manage in the future as we are managing nowadays as well.
Okay, thanks, Cullen. What about dedicated policy responses for primary care? Like, from the experience of your work, do you think that there's any better policy responses that could benefit the primary care response?
As I said about the guidelines for prevention and for treatment, we are in a difficult position because we don't have across Europe a general clinical guideline. There are so many, of course, developed by different organizations and institutions, but the clinical guideline for prevention in newborns, infants, young children, as I said, is developed nationally. It specifies the standards, principles, and fundamental aspects of concrete clinical case, which must be observed by practitioners regardless of the level of the health unit in which they operate. And as I said about the clinical guidelines, there are more rigid than clinical protocols being developed by technical development groups, respecting the level of scientific evidence and degrees of recommendation. And clinical protocols have a greater degree of flexibility, but in primary care we must follow in the first place the intuition, the clinical sense of the physician, and the experience and the rate of RSV infection in the community, and so on and so on. We are not so linked with the national guidelines regarding the treatment and follow-up of the disease. Of course, this is not an argument to don't follow the clinical guidelines, but as I said, the degree of freedom are different in different countries regarding the options of primary care.
Yeah, okay, thanks very much. So then, Susanna, moving on to an equally important part of the survey, do you think that nosocomial RSV is of significant concern?
Nosocomial RSV is a very important problem, especially for children with comorbidities. So we know that now, even with the issue of COVID, we are very careful with those that have not a result of a respiratory sample. But anyway, if you consider the last season and the summer, this is fine. But if now we are moving towards the winter, it is not easy because, for example, my hospital is very new. We have 10 beds of isolation that are with all the filters, negative and positive pressures, but we have also several rooms that are very beautiful, very large, but they are double room. And, now we have the problem of COVID-19, we have the problem of flu, the problem of RSV. This is not easy. And also because, of course, in the hospital, there are patients with usually with underlying disease, and this can complicate the management, the general management, also considering the need to be very careful with, with nurses, with medical doctors, and so on, while we enter the room of the different patients. So nosocomial RSV is a problem, this is clear. And of course, this can have an impact during next season. And this again highlights the importance of hygiene measure, including hand washing, but also, for example, for the wards, the washing of toys. Because yes, we can isolate all the children in their room with toys that are taken from the at the end the game room of the hospital. But then if we isolate the children, we put the toys in the room, and then we put all the toys together without washing them in an appropriate way. This is even worse than putting all the children together. Then there are patients like, for example, those with cystic fibrosis or with other, especially chronic respiratory diseases that represents a group that requires a lot of access in the hospital for the management of the disease, and then it will not be easy to appropriately distinguish between the different pathogens.
Okay, gosh, the washing of toys. Some toys are hard to wash, so there's a lot to keep in mind. Okay, I'm going to finish.
I see this because in Italy, for example, this is strange because the washing of toys is in charge of the volunteers, not of the nurses, not of the personnel that take care of the washing of the ward or the wards. So these volunteers are not informed that they are those that have in charge the washing of the toys that are put in the room of the children. So for this reason, sometimes there are nosocomial outbreaks that are due to very common pathogens like RSV and then sometimes rotavirus. Now, For rotavirus, we try to maintain the patients in specific beds for brief observation in order to avoid their entrance in the ward, but we are very expert of the risk of nosocomial infections due to viral pathogens.
Yeah. Okay, well, we've come to the end of our time, and I want to finish with one last question about the social, economic, and health impacts of RSV in your practice. I want to start with Francisco. Could you have a comment about what is the broader impact of RSV that you see in your practice? And we just have a couple of minutes left, so if I could ask you to do a sort of a summary comment, that'd be great.
Oh, yeah, definitely. So very quickly, I would say that it takes a lot of resources that needs to be derived from other diseases in order to attend these patients. And this is a major issue that we need to be aware of. And just to complement what Simon said, at this time with COVID-19, things are a bit changed because RSV patients are admitted in the same routes as COVID patients or whatever. They are respiratory patients, and this takes lots of time and resources, much more than it took before. So we need to be very, very aware of this. Very brief, so the others have time.
That was beautiful. Thank you. Can I ask for also a brief comment from Simon or Susanna? Do you want to add anything to the social or economic broader? Do you have any final comments?
Oh, what I can say is that we really need to be careful for the next season. So, I mean that we should remember that RSV exists, that in the previous years this was one of the main reasons of hospitalization in pediatrics, and we should remember that we cannot forget it because it can really represent a surprise, and the co-circulation of different viruses is always complicated in terms of health management.
Great, thanks, Susanna. Simon, did you have a final comment on socioeconomic?
Yeah, I think the burden on parents is really underestimated. I mean, the impact of having their baby, even if they're not that unwell, admitted to hospital, or, a significant number admitted to intensive care is huge. And, I think it was mentioned earlier about the need for parental education. I think that's really, really important.
Great, thanks for that comment, Simon. Javier, do you have a final comment you want to make on this?
Sorry, I was on mute. Yes, one last comment, and has a lot to do with this health management, and it's when assessing the quality of life lost by babies, that we have no way of assessing that. So we have had some approaches, but if we want to assess the quality of life lost by babies and their parents, we have no so far way of figuring that out. We can have some rough estimating using tools that are not adequate for babies. But studies that we're performing now, the quality of life lost by families and by the children is much higher than we expected.
Thanks for that comment. I think it's so important that we do pay attention to those broader issues, and I thank the speakers for doing that. We're now coming to the end of our time. I want to really thank the speakers for your participation. Your contributions are significant, especially to Javier, Susanna, and Simon, who are also co-investigators in the research we're doing. Your guidance and your expertise has been really important for this work. And it really tells us that this is long-term work that depends on decades of experience from people helping to make this better for health systems. So really, thanks for your generosity. And equally to Francisco and to Callum, really appreciate your support of the survey, of helping us get more responses and helping shape the thinking that we're doing. Your contributions today and to the survey have been very generous. I thank you all, and I applaud you, as I'm sure the people here in the room are doing. I want to also just thank Dr. Sanchari Dutta, and she's been the research lead on this project, and to Evelyn Donahoe, who's also been helping administer the research. Without them, we couldn't be doing this. Thanks to Sanofi for their support of this work, and Dr. Christian Felter for your really great comments today. Now, immediately after this session, there's going to be a 30-minute break, and everyone's invited to go to the networking zone, but also go to the expo area where you can see the Sanofi booth that we've put together on RSV, and that's where you can also find the link to the survey. And if you yourself are working in a field that's relevant, please do fill in the survey. But also, if you've got any ideas at all about how we can increase the reach of the survey, especially across Germany, France, and some of the other countries that you would have seen in Javier's presentation that we want to get more responses to. We've got a lot more planned, so we're very hopeful, but we really, as a community of practice, we look to you for your support and guidance. It's now exactly on time, and so we will end there, and thanks again for your time and support. Goodbye, everyone, and take care.
Thanks.
Thank you. Bye-bye.
Thank you.
Have a nice
Thank
day.
you. Bye.
Obrigado.
Obrigado. Até já.